Hello, this is Rachel Bavin from oncologynews.com.au. Welcome to another edition of the Oncology Journal Club. This week, Hans Prenen from Belgium gets us started with a fascinating paper on fasting. Craig Underhill looks at the stunning progress that has been achieved in lung cancer treatment over the last decade. And we have a very special segment from our host, Professor Eva Segelov from Monash University in Melbourne, who interviews David Fajgenbaum, author of the memoir Chasing My Cure, A Doctor's Race to Turn Hope into Action. David gave the opening address at ASCO this year, and we're honoured he could share his inspiring story with us. Watch out for the full version of the interview as well. It's an amazing story. Eva also has some quirky quick bites on Twitter, breastfeeding, and much more. We hope you enjoy another entertaining and informative episode of the Oncology Journal Club. As ever, the links to all of the papers discussed today are available in the notes. For the latest oncology news and podcast updates, please subscribe to the Oncology newsletter. You'll see a link at the top of oncologynews.com.au. This is Rachel Bavin, and this is the Oncology Podcast.
This is episode 7 of the Oncology Journal Club podcast. And this week, we've all been in therapy, so we know who we are. I'm Eva Segelov, you're Hans Prenen.
Yes, I am.
And you are Craig Underhill.
Yes, I think so. Everybody well?
Yes, we are, but we're hungry this week for information. And Hans has a really important trial to talk to us about. Now, I know you are very skeptical, Craig, but Hans and I really think there's something in this. Craig, this is a paper entitled Fasting Mimicking Diet as an Adjunct to Neoadjuvant Chemotherapy for Breast Cancer in a multi-center randomized phase 2 clinical trial published in Nature. What did they do, Hans?
So, Eva, thanks for this introduction. As you already mentioned, I think it's an extremely important paper because it's a concept and I really like it and I really believe it could change in the future the way we're treating patients in combination with diet. The trial is called the DIRECT trial and it's from my colleagues in the Netherlands. And they're actually based on preclinical evidence that suggests that short-term fasting and fasting mimicking diets, they can protect healthy cells against chemo, rendering cancer cells actually more vulnerable. So why is this? Because fasting causes a switch in healthy cells towards a maintenance and repair state, while cancer cells seem to fail to adapt. And this phenomenon actually has a name. It's called DSR. Do you know, Eva, what it means, DSR?
I don't. You've got me there.
So it's differential stress resistance. So we will never forget this DSR. And what did they do in this trial? They did fasting periods of at least 48 hours. The problem is you cannot completely fast each time you get chemotherapy. That's why they use a fasting mimicking diet. And it's actually a very low calorie, low protein diet. And it's quite similar to have the same metabolic effects, similar to if you would only drink water as fasting. And they did a randomized study and they evaluated the impact of this fasting mimicking diet on toxicity, as well as on radiological and pathological response in chemotherapy neoadjuvant for breast cancer. They randomized 131 patients with HER2-negative stage 2-3 breast cancer without diabetes, so that was an inclusion criteria, and also the BMI had to be over 18. They gave this diet for 3 days prior to and also during the neoadjuvant chemotherapy. So what were the results? There was actually no difference in toxicity, despite the fact that the dexamethasone was omitted in the diet group. Complete response or pathological response on imaging was much more frequent, so significant more frequent in the diet group. 47% versus 28%. And there was also a trend for an increased pathological response. And they also found that the more cycles of the diet you adhere to, the higher the pathological response. So is it practice changing? I don't think so yet, but the data really encourage further exploration of the benefits of fasting, or call it the fasting mimicking diet, in patients receiving a wide range of cancer therapies.
That's a fascinating paper, Hans, and I love the term of a fasting mimicking diet. I can see, Craig, you're tucking into a hamburger there. Is that what you're on?
I wish, Eva. It is Friday night, and I would probably prefer to be tucking into anything at all. But I'm just a little bit skeptical that this is going to turn out to have any real benefits in patients and really applicable to the everyday practice.
It would certainly be tricky to counsel some patients to fast while we're also trying to counsel people about their nutrition. However, we do know, particularly for early breast cancer, that weight loss is a really important factor for relapse. So these things will all get mixed together. But there is definitely, I think, a metabolic state of the cell influenced by the fasting state and an interaction with chemotherapy. So I would say watch this space. Hans?
Actually, I really love the concept because it has been proven in so many preclinical trials, in mice experiments, and I think now it's for the first time that we see also this difference in patients. But I fully agree that it's not something that we can do in all cancer patients, also in the metastatic setting. So I think it's very good that they tried this in the neoadjuvant setting, in this case, in the population with very little disease, where it's feasible to do so.
Yeah, but come on, Hans, you can cure mice's cancer by giving them red cordial. So do you really think fasting people for 48 hours is going to be practical?
Yes, Hans, I'm a little confused too. What did they actually eat?
So actually, they didn't only fast for 48 hours. So they start the diet 3 days prior and during the chemo. So that was the tricky part. And actually, it was a plant-based, low amino acid diet. So actually, you can eat soups, liquids, broths, tea, and they used complex carbohydrates to have the main macronutrients. So I have to admit that it possibly is not feasible in all patients to be on this very strict diet. So, but this is something I think has to be studied.
Yeah, come on. Move on, Hans.
No, hamburgers are complex carbohydrate.
Are they? It's mainly fat.
Mm.
So after this very interesting paper I just discussed, I would like to give the word to my brilliant colleague, Dr. Underhill, who will lead you through the stunning progress achieved in lung cancer over the past decade. So Craig, the floor is yours.
Thanks, Hans. It really has been stunning progress in lung cancer in the last 10 years. From an era of therapeutic nihilism, we've moved into an era of rapid progress and driving down of mortality rates in lung cancer. So this was an overview published in the Lung Cancer News by the International Association for the Study of Lung Cancer. Goes through surgery, radiotherapy, but in particular looks at the better understanding of molecular biology, which has driven some fantastic progress with rational development of drugs. So interestingly, just in the last couple of months, some data from the US is showing the largest drop ever in 5-year mortality rates across the board for cancer. And the hypothesis is this has been driven by the progress in lung cancer, which of course is one of the most common cancers. So for those of us who work in lung cancer, it feels every day like we're in the middle of this incredible revolution in treatments. I'm hoping that everybody, by reading this paper, will get a sense of that revolution and feel some of the passion that we all have in this space for those of us who treat patients with lung cancer.
And what do you think, Craig, is the biggest achievement here? Is it the immune therapy, the targeted therapy, or what is the focus on?
Well, it's both. So, lung cancer is really made up of many different diseases that start in the lung. And so through the understanding of the molecular biology and what's driving the cancer, and then finding a targeted therapy to apply, we've seen in the various subsets of lung cancer incredible progress. And then overlying that is immunotherapy, which really has benefit across the board. So like in melanoma, we've seen immunotherapy, on a daily basis in the clinic, having a huge impact in these patients.
And do they also discuss, let's say, repeated biopsies? Because as you know, the behavior of the tumor can change under selection of some drugs, no?
No, they don't. There's been some interest in that space because we're finding that some of the subtypes can actually, as you say, evolve. And so, for example, some of that ALK1 positive patients may change into an aggressive subtype of small cell lung cancer. So it's an interesting space. So, we know in breast cancer that there's probably merit in repeated biopsies, and there's some interest in that space in lung cancer as well.
It is quite incredible that the molecular subtypes all make up together a significant proportion of cancers, unlike in cancers of many other sites of origin where they're really just affected a few percent of patients. So, Craig, you recommend this paper to both lung cancer docs and non-lung cancer docs?
Yeah, yes, Eva, it's a great question, because I think it's probably a model of how we maybe need to approach other cancers where there hasn't been as much progress, and maybe glioma, pancreas cancer and others are an example where we need to go back to the drawing board. We need to understand the molecular biology before we're going to see substantial improvements in outcomes.
So that's a great segue into this episode's interview. It was a great privilege for me to interview Professor David Fajgenbaum, who gave the opening address at ASCO this year. And what a shame we weren't all there in person. I had goosebumps while I was listening to his story. I will be presenting the full 1-hour interview in a separate podcast. But for this Oncology Journal Club, here's a little snippet. And please listen to the full podcast. It'll be really an hour worth your while. So this is a really special podcast. And I'm really excited and humbled and awed because my guest is David Fajgenbaum. He's an MD, MBA, MSc, Assistant Professor of Medicine at the Prenen School of Medicine at University of Pennsylvania, and the Executive Director of the Castleman Disease Collaborative Network. He's the author of a book, Chasing My Cure, A Doctor's Race to Turn Hope into Action. And his story is so incredible that every time I see it, I can't help be overwhelmed with emotion. How it came to having the opportunity to interview David is that he gave the opening address at this year's ASCO meeting. Now, being a virtual meeting this year, ASCO was harder to engage with, and I'm worried that people miss this absolutely inspiring an important session. But I think there will be great interest in this from not only oncology, but from rare diseases.
Well, Eva, thank you so much for having me on today.
Welcome, David. So as I've said, you've got an amazing story, and I'll ask you, if you don't mind, to tell us. You were a perfectly fit third-year medical student one day, and then what happened?
Yeah, I was training to become an oncologist in memory of my mom, who had passed away just a few years before from brain cancer. And out of nowhere, I just became deathly ill. It really started with fatigue that I had never felt before. I noticed some lumps and bumps in my neck. I noticed fluid accumulating around my ankles, and it all just didn't really seem to make sense. And I was busy as a medical student. I was, trying to become a physician. And there's, as you know, there's no time in medical school to be tired or to take breaks. And so I just kind of kept pushing through. And I started getting really bad abdominal pain, and I really wanted to see a doctor, but I knew I just needed to make it through this one particular rotation that I was working on. And so I just kept working. And I took my exam, and then I went down the hall in the hospital to the emergency department and to try to get checked out. And they ran a series of blood tests and came back and said, David, your liver, your kidneys, and your bone marrow are shutting down. We have to hospitalize you right away. And they did a full body CT scan at the time, and came back with disseminated lymphadenopathy, and in the setting of flu-like symptoms, plus many enlarged lymph nodes, plus some really abnormal organ function. It made everyone really concerned that this was lymphoma. And unfortunately, this would be the beginning of a very long diagnostic odyssey. Over the next 11 weeks, I gained about 70 pounds of fluid. I had a retinal hemorrhage that made me blind in my left eye. I needed dialysis because my kidneys completely failed. I needed daily transfusions because my bone marrow wasn't functioning appropriately. And I was so sick that a priest came in and administered my last rites to me back in November of 2010. And I've really considered that moment to really be the start of my overtime, this sense that, and I'm sure the listeners will appreciate that well from a different kind of football than I'm used to, but extra time you didn't think that you'd have, but time where you really have to make the most of it. And thankfully, right around the time that I nearly died for the first time, the diagnosis was finally made. Idiopathic multicentric Castleman disease. And I was started on treatment and my life was saved, but unfortunately I would go on to have relapse after relapse after relapse.
Do you remember the priest coming in, or is it just something that family have told you?
I have some vague memories from that experience. Because my liver and kidneys were shut down, I was very confused. My BUN, for the physicians listening to this, blood urea nitrogen was over 200 milligrams per deciliter. So it was very, very, very high, like 10 times too high. So my kidneys just were not functioning. I was on dialysis, and I was very confused. And so I didn't really know exactly what was happening, but I was scared. I guess I had enough sense to know that things weren't good, and I was really afraid.
So what treatment did you have at that stage, David?
I got a single dose of rituximab. It's interesting because at the time there was a clinical trial for idiopathic multicentric Castleman disease going on just down the road. My doctor at Duke did not actually know about the trial going on just down the road and really tried rituximab, which is typically not very effective for the subtype of Castleman disease that I have. But that was the only drug that he was aware of could be tried. Thankfully, that single dose of rituximab quieted things down enough. I continued to get weekly doses of rituximab for the next few weeks, but then I quickly relapsed, and rituximab was never effective in future relapses, but it worked, and that's I guess all that mattered. It got me through that, and unfortunately, I would need many more intensive therapies moving forward.
So coming back to your address that you gave us at ASCO, can I ask you, what are the key messages that you'd like us as oncologists, as well as fellow humans, people who have our own illnesses, families with illnesses? What are your key messages for us, David?
So I started my talk by sharing my different perspectives as a patient with Castleman disease. I actually also had a rare liver tumor called an inflammatory myofibroblastic tumor. So I've experienced oncology in a couple ways. But as a patient, as a caregiver of my mom with cancer, as a researcher, as a physician, and then also as an advocate, how these perspectives have been really critical to the progress that we've made. I talked earlier about crowdsourcing, and really at the heart of it, it's not about the fancy term like crowdsourcing. It's really just about bringing together multiple perspectives. And so I encouraged, and this is oncologists, but really anyone in the sciences or in medicine, to make sure that you're including all of those perspectives in the work that you do, whether it's on an individual patient basis, including all 5 of those perspectives for your patient in front of you, or it's across a disease. So you're really pulling them together, and even across multiple diseases. How can we Castleman's researchers work with related disease researchers like COVID-19 researchers? And so really encouraging this sort of cross multi-stakeholder effort. I think that's just been so critical to our success, and I can't encourage others enough about how badly that needs to be done. I shared a few messages from those perspectives. So the first was that hope can have many forms. There's the kind of hope that made me feel like maybe I could survive when I saw another Castleman's patient that was doing much better than I was, and maybe I could be like him. There's the kind of hope where you hope and you wait for that cure to come, which is the kind of hope I had with my mom. I just believed and hoped with everything that I had that she would survive. And then there's the kind of hope that we've talked about already, and that's the hope that inspires action, where you say, okay, I'm hoping for this thing. I'm going to do that thing because I'm hoping for it. And it doesn't have to be curing a disease. It could be that, you hope to spend more time with your grandkids. So maybe you're going to exercise a little bit more. Maybe you're going to take your diabetes medication. There are ways that you can turn hope into action that don't require experiments. I also shared about the power of humor and how during really tough times, finding things to laugh about are really important. And I don't want to generalize too much, but I have to say my Australian friends are so good at finding humor at the right time. It's like again, I don't want to be too generalistic, but wow, Australians that I have dealt with, it seems like you guys just have this knack for during really tough times finding the right time to laugh about something. And it's not inappropriate laughter. It's like, how can you find some lightheartedness in the midst of a tough time? I think that's something that us Americans can do a better job of. I also shared about how there can be solutions that hide in plain sight, like the drug that I'm on, and how we shouldn't just think always about new drug development, but we should also think about the drugs in the rearview mirror. And I talked about how something we mentioned earlier, that it really does take an army, that if this was me on my own, we would have made no progress. But because I had this amazing army, and it should be chasing our cure, because it really has been an army working together to chase our cure. And so those were a few of the messages. And I think just one that I would end with that we touched on once before, and that's the idea around creating silver linings, that during a tough time, don't just look to say, okay, something positive came from this, but let's say, what can I do today during this really, really tough time to make this into something that's positive?
So, David, you're everything rolled into one, and it must be quite cheap to have a conference with you, because you can be the patient, the advocate, the researcher, the doctor, the businessman. I can't thank you enough for being so generous with your time and with your personal story. I think you're an inspiration, but your way of thinking and changing that paradigm is really something I think that may help accelerate us in research from the relatively modest progress we've made for all the money and time invested.
Well, thank you so much. It's been such a pleasure being on the show with you. And I so appreciate you helping to share our message of hope. And it's also so special that you're helping to share tangibly how we're trying to change the medical community. So thank you.
Oh my God, I'm really looking forward to listen to the full podcast.
Yes, an amazing experience for me having the opportunity to interview David. So now to our short bites. And the very first one is critical. Does tweeting improve citations? 1-year results from the TSSMN prospective randomized trial. This was published in the Annals of Thoracic Surgery. Who knew those guys were so cool? Available online 3rd of June 2020. And what they actually did is their society, the Thoracic Society Social Media Network, which is a collaboration of leading journals in cardiothoracic surgery, did a randomized prospective social media trial. 112 representative original articles randomized 1-to-1 to either be tweeted about or not. And the 1-year follow-up said that tweeting significantly increases your article citations, highlighting the durable scholarly impact of social media activity. So, Craig, do you know what altmetrics are?
Never heard of it, Eva. But I'm assuming you're going to tell us.
I am, because you need to know. It's the little coloured circly bit when you look up the metrics on your publication. And it was developed because people now get credit for how many tweets they get or Facebook likes. So it's actually used in academia. It can include citations on Wikipedia, discussions on blogs, mainstream media coverage, bookmarks on reference managers like Mendeley, and of course, Twitter mentions. So in all of our journals now, you'll see an altimetric number, and that's what it refers to.
That's interesting, Eva, because Google rankings for businesses are not only based on visits to websites now, but it's actually about their interaction with the community through social media. I guess this is a similar kind of concept in academia.
And Hans, you'll verify, you joined Twitter about the same time I did. You hear breaking news, people tweet out of conferences, journals tweet. It's actually really an academic activity, apart from some of the other rubbish.
I'm assuming at this point, Eva, you're wanting me to ask, oh, Eva, how many Twitter followers do you have compared to Hans?
Oh, that's a good one. I haven't looked recently, but it's a bit like the situation with podcast listeners in Australia versus Belgium.
I must say, I already have 71 followers.
I'm just looking up my altimetrics now. I have 170 followers. I like the really random one.
Christopher Steer, who we had on 2 podcasts ago, times 20, Eva.
20 times a better Twitterer than me then. Okay, the other quick bites. JAMA Oncology in June published a paper showing an association between breastfeeding and ovarian cancer risk. Almost 1,000 women with ovarian cancer and 14,000 controls. Breastfeeding was associated with a 24% reduced risk of invasive epithelial cancer. My next short bite, immune checkpoint inhibitor re-challenge after IRAEs in patients with cancer, JAMA Oncology, April 16. So this is an observational cross-sectional pharmacovigilance cohort study. It examined the individual case safety reports of around 24,000 immune-related adverse events and showed around a 28.8% recurrence rate of the same IRAE that the treatment was discontinued for after a re-challenge. So interesting information, useful when you're talking to patients.
So that means either 72% of people weren't experiencing the same side effect if they were re-challenged. So that's really quite interesting.
Obviously, people with severe side effects may not have been re-challenged, but in those it was to re-challenge. Exactly right. You can tell people they've got about a third of a chance of getting the same side effect again. Now, the old question of whole brain radiation in small cell lung cancer, that's been around for a while. This paper published June 4 in JAMA Oncology, evaluation of first-line radiosurgery versus whole brain radiotherapy for small cell lung cancer brain metastases from the FIRE small cell lung cancer cohort study. Again, a multi-center cohort study, not a randomized trials, looking at outcomes. Around 710 patients who got first-line stereotactic radiosurgery showed a median overall survival of 8.5 months. Median time to CNS progression was 8.1 months. And their conclusion was that if you control for multiple prognostic factors, whole brain radiation compared with the stereotactic radiosurgery was actually associated with a superior time to CNS progression, but offered no overall survival advantage. And the comment was that we do need a prospective trial to answer that question of which is best. And now our favourite part of the show, it's
PBS update. So Eva, another quick update from the PBS. Now, we don't necessarily endorse these treatments, but we just want to bring people's attention to new treatments as they're listed. This one is trifluridine tipiracil, which is now available as a third-line treatment in both metastatic colorectal cancer and metastatic gastric cancer. So another treatment option really for patients who failed multiple therapies.
an oral drug, not without toxicity, TAS 102, but good to see it come on as an option.
That's right.
So that brings us, sadly, to the end of another eclectic, interesting, informative, and hopefully entertaining Oncology Journal Club podcast. Another plug for our interview with David Fajgenbaum, coming out shortly as its own standalone podcast. But for now, it's goodbye from us in Australia, Craig.
Goodbye, Eva. Thanks very much.
And goodbye to you, Hans.
And goodbye from the sunny Belgium.
And thanks to our wonderful producer, Rachel Babin at Oncology News.
Thanks. Bye, guys.
You've been listening to the Oncology Podcast. If you enjoyed today's edition and would like to subscribe, head over to our website, oncologynews.com.au, and sign up to our newsletter. Thanks for listening.